Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Hello, and welcome back to the Sit and Stay podcast brought to you by RipsyTech. I am RipsyTech's product manager, Parker Anderson, and as always, I am joined by the amazing founder and CEO of RipsyTech, Tom Tarshis. Hey, Tom.
Parker, nice to see you, sir.
Nice to see you, too. It feels like it's been a while since we've recorded, although the audience, they don't know that. Feeling a little under the weather today, so I hope my audio quality, if you think I sounded exceptionally good today, don't get used to it because it'll change the next time.
It sounds pretty good. We'll see if anyone notices a little more nasal but deeper tone also. So.
Oh, okay. Good for podcasting. All right, so before we dive into this week's topic, every single week we like to dive into different topics that pertain to, the business of running a mental health practice. Before we dive into this week's topic that you're probably seeing in the title of this episode, I just wanted to provide some quick updates that if you are new to RipsyTech, we have a course. Go to a course on how to start a private practice. Go to ripsytech.com/practice and check that out. If you are, thinking about starting your own practice, want to take the leap, it's a great resource that we offer for free for getting that taken care of with, professional guidance. All right. Before I completely crash out, losing my train of thought, being sick, I'm going to pass it over to you, Tom, to introduce the topic, which I believe overarching, I would say, is legislation in mental health, in the mental health field, and how it pertains to being a mental health provider. So I guess I would why should mental health clinicians care about legislation in the first place? And I have a follow-up to that as well.
Gotcha. Yeah, and as people who listen to the podcast know, kind of whatever I've been working on intensely or differently or in the moment brings up a lot of ideas for our podcasts. And I've been part of CSAP, which is known as California State Association of Psychiatrists, for some time now, possibly a decade, but I've sort of, would be at meetings and look at, that is a group that looks at California legislation around all sorts of mental health issues. There is a lot of a lot of legislation that happens around healthcare and mental health. And so at any one time there could be a dozen or more pieces of legislation, which we'll talk a little bit about. I'm not great on the civic stuff, but recently I've upped my involvement to do more within the local sort of San Francisco region, and also push more within the state of California. And it's because of some legislation that is very detrimental to mental health practice. And the thing that put me over the edge was an insurance company saying that you need to justify, if you're a psychiatrist, you need to justify why therapy is medically necessary every visit. And that, sometimes when these things come down, the only venue you have to fight back is through laws. And we're going to talk about some of that, but that's why this has been on my mind.
Yeah, that is absurd. You mentioned that in the past couple of episodes where we kind of talked about recent insurance situations, and so go check those out if the listener is interested. Go check those out. But the more I've thought about it, the more it is kind of a head scratcher on why a mental health provider, I mean, you're a doctor doing medications. I can't imagine any version of seeing a psychiatrist where maybe, I don't know, maybe not for like an ADHD medication refill appointment, but like therapy seems like just such a crucial component to seeing somebody when it comes to anything having to do with your brain and your mind.
Right, right. And we're talking, well, and if people are interested, and we can put the link up. I wrote an editorial on this topic that went out. And yeah, I mean, it's the problem is it is the gold standard for treatment for lots of things. It's what, specifically for psychiatrists, a lot of our training is around that. You could argue that learning the medications is very, very algorithmic and actually doesn't take a lot of brain power, especially with AI tools these days. And so it's really, though, your skills in therapy and knowing the right therapies and how to do them. We'll see what happens with AI. Never say never, but I do feel like even if AI has the perfect tone, language responses, the fact that it's being delivered by a non-human is going to make the outcomes not good. We'll see. There's some interesting stuff, and I love technology. So, yeah. But anyway, that's what that's what has spurred, like, okay, well, at this point in my life and career, we need to push hard on lasting legislation to protect our patients and them getting the best care.
So, all of this is kind of help answer this question of like, why should a mental health clinician care? And I think this is a great recent example. Do you have any kind of past examples of times where legislation affected your ability to deliver care?
Yeah, and I think that a lot of things that happen in this country are from laws, and there's federal laws, and then there's state laws, and this has to do with all sorts of topics. But Parker, what's the difference between a federal law as it relates to then state laws within whatever state you're living?
Tom, the audience told us they didn't want us to do these little Parker, what is this thing that I have the answer to? No, but I mean, if I just for the sake of me thinking it out, the difference between state and federal, my interpretation of this has always been, federal is kind of like the big umbrella, like this is the default, like this is what we say goes, and the states have the ability to kind of put their own spin on most of those things to say, okay, well, this is our state-specific version of this, but if we don't have a state-specific version of this, it's the federal version of this. I don't know if that's like a drastic oversimplification, but that's kind of how I've thought about it.
Yeah, and Parker, what is the right predicate to use when you're... No, I'm just being funny. I do recognize that feedback, although sometimes when I feel like I'm droning on too much, and haven't reached the end.
Yeah, you got to get me chatting a little bit more. I understand. I appreciate it.
Yeah, or if I need to clear my throat. But anyway, yeah, I mean, you sort of said it correctly. Good, easy examples are like there's a federal minimum wage law, and so everyone has to be paid. I don't even know what the federal minimum wage is right now, but I know then there's state minimum wage laws. I think in California it's close to $17. And then, of course, there is also then county and city levels of government and laws, although that doesn't tend to have such a formal legislative process as state and federal. But the deal is, if there is a state that doesn't have like a minimum wage law, then the federal law would apply. If there's a state law that is better than the federal law, that would be what you need to pay attention to. An example of a federal law specific to mental health practices would be sort of HIPAA laws around patient confidentiality and protections. I don't think there's any state that has made a more restrictive or different law around HIPAA, which is good because, well, that's another boring... We won't do a podcast episode on HIPAA, but Yeah,
I think most people are familiar with it.
Yeah, and although we could talk about some nuanced problems with it, but in any case, so we need to know about federal legislation around things like HIPAA and laws we need to follow in mental health practice. But then there are some key pieces. There are some big reasons why we want to know about federal legislation and then state legislation.
Yeah, let me just very quick kind of interrupt with like an example of how, like a simple example that people can understand between like the difference between federal and state, because you're talking about minimum wage and how the minimum wage in California is $16.90. I just looked up, and the federal minimum wage is $7.25. But the state of Georgia that I live in, the minimum wage is technically $5.15 under state law. But because it's lower than the federal minimum applies to most employees in Georgia. But there are certain situations like having being an employer of like 5 or fewer employees, or like tipped positions, where the $5.15 rate can still apply. So I guess my oversimplification earlier is almost kind of, an oversimplification, but just kind of goes to show why knowing the difference and how it applies is very important. All right,
Yeah,
go ahead.
and Parker, yeah, no, that's actually a perfect example for the big law on the federal level for mental health care came out in 2008. And it has this beautiful acronym, MHPAEA. No, I'm joking, of course. It sadly couldn't come, most people could try to come up with something that's a little more easy, but
Yeah.
Anyway, it stands for Mental Health Parity and Addiction Equity Act. And it was a big federal legislation signed by George W. Bush, yes, in 2008, that essentially said, hey, you've got to treat mental health and addiction the same way you treat other medical services. So before 2008, if you didn't, you could do anything you wanted regarding providing coverage for things like depression or anxiety or alcoholism. And the insurers definitely took advantage of this. And so you couldn't get,
Really?
It was hard to get treatment. It wouldn't pay the same. And it was this is maybe, we're still a long ways away, but it was a positive, and it was the federal government saying, hey, this isn't right. Mental health and addiction affect massive percentage of the country, and so let's pass some law to provide right benefits. But to your point, it didn't mandate, right? So it's sort of like, if a plan provides mental health benefits, they have to be on par with the medical benefits.
Okay.
There are other exceptions as well.
Well, I guess, like, for the sake of painting kind of a clear picture, like, what were you a practicing mental health provider prior to that decision, and was that did there feel like there was kind of like a clear difference?
We started in 2007 initially, and at that time California already had a little bit of protections in there around mental health coverage. But it is true that at the beginning, when things started, right, 20 years ago, you couldn't see someone for depression or a mental health diagnoses without calling and getting authorization to treat the mental health.
Wow.
So, yeah.
Wow.
Every single, there were a few plans that maybe, well, California was the first in saying, like, if you have these, I think 6 diagnoses, so it was like major depression. It was like, severe-ish diagnoses. And so, of course, there was bias towards seeing if getting one of these diagnoses for your patient, so you didn't have to do a painstaking phone call to get authorization. I forget what that legislation was called, but that had already existed in California. And yeah, so that 2008 act was a big federal one. There are still lots of exceptions to that act, and so almost every state has some laws that do better than this law. So, for example, there are still things that could be done around co-insurance authorizations. Are you providing all the levels of care? But are they excluding certain diagnoses? And so again, luckily us living in California, we have this legislation SB 855 that passed a few years ago that really tried to wipe out all these little exclusions that people could still use. And we're very appreciative of that. So this is where whatever state you're in, being acutely aware of the mental health legislation that's in place in your state helps you, whether or not a lot of legislation is aimed towards commercial insurance. A lot of it is aimed towards Medicaid services. But there is other legislation, even with respect to people, right, paying cash or out of network clients. So it behooves everyone who is serving patients to know what are the laws that affect them as a mental health provider and that affect their patients as people coming to see them and get services.
All right. Is when we talk about access to care, the accessibility of care, how much of that really does come down to policy and rules made up by insurance companies?
Yeah, so right, almost everything really. So, and we've talked about our capitalistic for-profit, highest GDP, the healthcare industry issues. And what was I forget who I was talking to, but it's an interesting thing where now, given what is AI doing to the workforce and all the jobs, you hear people, the safe career shift is people are talking about, I'm going to go do something in healthcare because that, it is this, where is there a lot of dollars? Where is like something like being a radiology tech or, there are, until the AI robots are around, there are these jobs within the healthcare industry that pay reasonably well and are less susceptible to AI. So new graduates and other people worried about job security are shifting towards healthcare because so much money goes into healthcare. But you look thoughtful. Question, or should I keep going?
Oh no, I'm just thinking. I'm thinking about AI and its impact on everything, and how the human element, I think, is my view. I could end up being wrong on this, but just my view with AI and its impact on multiple industries is that we are going to value the human experience more, be more willing to pay for the human experience. I think where AI can replace things, it will replace things. Or not replace things, but like it'll wiggle its way in on the cheap, so to speak. But people will always pay a premium for people. Whether that's, do I want free AI slop or do I want the Christopher Nolan movie made by human hands? And, I'm going to pay money for the Christopher Nolan movie made by human hands. In this case, it's am I getting my therapy and medication from a robot, or am I speaking with a human being who deeply understands my emotions and mental well-being? But I also was thinking about, are there certain actions that are performed at hospitals that will be replaced by mechanical robot arms or something? I mean, I just watched Project Hail Mary. He had a robot for that on his little spaceship. So will that happen? I don't know. Just my fun little musings.
Gotcha. I didn't see the movie yet. Thanks for ruining it for me.
Oh yeah, the robot arm. It's all spoiled.
And just to pull out, Parker's a cinephile. What if the Odyssey's terrible and you hate it? Are you still going to be a fan of the Christopher Nolan movies?
Well, yeah, because Tenet was not the greatest movie ever, but Oppenheimer still won Best Picture. Anyway, we don't need to get into it.
Yeah, very good. Yeah, no. So I mean, the way things work, and we'll talk about, the healthcare system is driven mainly by insurance and services, and it's a huge. I think it's maybe the number one lobbying piece.
Yeah.
American Medical Association. There are some of the lobbying groups are the biggest lobbying groups are around this healthcare piece, right? In general, we have Medicare, which is insurance for everyone once you hit 65 or on disability. So the federal government makes these Medicare laws, and in general, the commercial insurance companies kind of follow those laws for offering reimbursement for different services, and it's not always the case, but people watch what Medicare does and then will in general follow suit. That being said, anything that can be done to help drive shareholder, profits up, they are for-profit corporations, so that's their mission,
Right.
is the default. And we can claim that that's not mutually exclusive with providing good care, and on some level that's true. You would want to, but the way the system is set up with like providing good care tends to fall on hospital. People don't actually necessarily think about it as their insurance carrier. They think about it as providers or systems. But so what happens is it's up to the federal government, put some of these restrictions in place, but individual states, for commercial insurances operating in individual states, they have to abide by those individual state rules. And it is true in general, there are some national insurances that you can negotiate on a sort of for a national contract, but in general, you're always negotiating within a state specific piece of a large commercial insurer. Go ahead, Parker.
I've gotten so good at non-verbally indicating I want to say something. You mentioned earlier that people like to watch Medicare to kind of get a sense for what things might be on the way. Because, the final question that I had for you was, what should clinicians be paying attention to when a new mental health law or policy is proposed? I mean, it seems like Medicare is one thing that they should be paying attention to. Is there more you want to say about that, or are there other things that they should be paying attention to?
Yeah, so Medicare is really important to, if you take commercial insurance, being aware of what's happening, or if you're just any healthcare provider of any type within the United States, you want to pay close attention to what Medicare is doing. Are they putting in a new billing code? Are they increasing reimbursement for something or decreasing? We'll see what happens with telehealth, where Medicare has sort of been leading the way on some of the telehealth pieces. I think for mental health providers, being aware of laws that have been proposed or going, it's a long process. And I think we'll talk a little bit more about this in the next couple of podcasts that we'll do about this topic. But, the process to get legislation in place is a multi-year process.
Right.
But this is how you do create lasting change. It is impossible to make things happen quickly. The one piece I wanted to throw in with respect to the federal and state differences for mental health parity laws is that there still are these sort of loopholes for insurance companies to get away with going to the, avoiding the state specific laws and defaulting to the federal ones. And some of these are you can do these federal self-funded ERISA plans that a major insurance company might be the administrator, but the company has elected this federal ERISA plan, which means they're not subject to whatever is going on in your state, and it just falls back to the MHPA EA Act. And so we have people in California And again, these companies are not aware of the specifics usually, but they see
Right.
that it's a cheaper option depending on the size of your company. Some Yeah, there's some sneaky stuff around there that we'll talk about later. But I have families that, even I thought that they were, subject to the California laws, and we were fighting to get their kid coverage. But then it was, hey, no, this is actually a federal ERISA plan. It says it nowhere on the insurance card. Like, it's this ridiculous. How would
Oh,
anyone
wow.
know,
Yeah.
or even know the different? Hey, so sorry, you can send it to the California Department of Insurance as a complaint, but they'll say, we forwarded this to the federal level, because it's not subject to the California plans. And then that derails, in California, there's all these protections around when someone needs to be seen, driving distance, in person.
Right.
All that's thrown out the window when it defaults back to the federal parity guidelines. And that is important for providers to be aware of.
Goodness. Okay. I mean, this has been a great kind of overview, I think, just to kind of get started on discussing this topic. We are planning to have more discussions about this. Anything else you wanted to say before we kind of move to the next piece?
Yeah, no, I think that we're there. I think the goal was let's just do a little discussion. The fun stuff, or what is sort of interesting, is we'll pick some specific states and legislation to dive into and see. There's one very interesting piece of legislation that almost made it through, and like to see where the support was and where did it die. And you know politics are very bipartisan these days. However, mental health legislation tends to not be as controversial. It has support from both sides, and
Right.
which can be a positive. But yeah, we'll target some specific state laws, and then I think as with everything, we want to push a little. Hey, if you're interested, we need more providers to like be part of this process. And a lot of legislators pay close attention to clinicians who,
Right.
as experts.
Okay, great. This has been great. Now a word from Rye, our AI mental health practice advisor.
This is Rye, your AI mental health practice advisor. Practice owners often ask, how do I avoid financial panic in my new practice? The best way to avoid financial panic in a new practice is to plan your startup costs and set aside a contingency fund for unexpected expenses. First-time business owners should also involve an accountant early to avoid budgeting and tax surprises. For more practice advice, ask me a question at RipsyTech.com.
All right, Tom, it has been a second since we have recorded. Like I said at the top of the episode, the audience might not know that, but I haven't gotten a mental health business moment from you in a few weeks. I'm curious what's going on over there.
Well, Parker, and I think I've mentioned it here. I am licensed in both California and Hawaii,
Oh,
and
right.
our California nonprofit has been busy under the tutelage of our executive director, who is not me. And so a lot of energy has been focused there. But recently I was like, okay, well, let's, I got some data on insurance rates in Hawaii, and let's do some steps forward there. And I have a colleague there. And, and I got a notice, like I thought I had been incorporated, or not incorporated in Hawaii, but that I had had permission from the state with my California certificate of good standing to open our Hawaii office and begin operations. And I got a letter back saying, hey, we tried to do your yearly renewal, and Hawaii's like, we don't know who this is. And I'm like, yikes. And so it turns out Hawaii's a smaller state, and I had actually been communicating with a helpful individual. And I found an email it was from last October, where they had said, hey, there was a little mistake on this form. I can correct it for you and push it through if you like. or you can like redo it. And I'm like, oh yeah, no, please, you go ahead and do it. They had never done it actually. And so we had not existed in Hawaii. However, with quick reaching out and forwarding the old email, they were like quite apologetic and said, okay, we'll push it through. And, within like 2 days, we got our, you're good to go. So, which was nice. Yes. Nice.
All right. Well, thank you for the update on that. Yeah, haven't heard up on the Hawaii clinic in a second. All right, that's it for this week's episode of the Sit and Stay podcast, brought to you by RipsyTech. If you enjoyed the episode, we would love a rating or a review wherever you are listening. And if you'd like to get in touch, you can email us at sitandstay@ripsytech.com. All right, Tom, I will chat with you more later.
Thanks, Parker. Feel better soon.
You too. Well, thank you. Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.